You're listening to Stellar Success, Leveling Up for Medical Pros with Dr. Tudor Francu. Join us as we explore how medical professionals can achieve stellar success in all areas of life. It's time to level up.
Hello, everyone. Dr. Stone from Vail, Colorado is with us today. How are you, Doc?
I'm fine, thank you.
Thanks for coming. I want to kind of give the audience a little bit of an overview of your professional career. How did you start in that?
Well, I started by going to medical school at the University of Maryland, Baltimore, and then I decided to pursue a surgical career. So I ended up spending a couple of years in surgical residency, then 3 years in urologic surgery residency. And then I decided to become a specialist in that field. So I moved to New York City and spent 2 years at Memorial Sloan Kettering Cancer Center, becoming a urologic oncologist. Also spent a couple of years at Rockefeller University learning about biochemical endocrinology. So I have a sort of a broad background in both research and in urologic oncology. And after that, I became chief of surgery, urologic surgery at Elmhurst Hospital, part of the Mount Sinai system in New York City, where I've been now for almost 40 years.
Very interesting. And I know you developed some of the new technologies in detection of the prostate cancer, right?
Yes.
Can you tell us a little bit more about what's going on with that and what do you want to accomplish?
Yeah, so my life as a practicing urologist has not been your typical physician who does your see patients and treat patients in our field. Of course, it's mostly urologic cancers. Um, I always was a bit of an innovator. So I started off my career not only teaching residents how to properly perform urologic surgery, but also figuring out how to innovate new technologies and trying to determine what's best for our patients. So I started with some colleagues back in 1989 with the introduction of prostate-specific antigen or PSA screening, which is a new test, a new blood test for prostate cancer detection, but it hadn't been utilized when it was first introduced in the late 1980s for detection. It was introduced once a man was diagnosed with prostate cancer. So we set up a foundation called the Prostate Cancer Education Council, myself and several colleagues, and we started offering nationwide prostate cancer screening evaluations third week of September. First one was in 1989. And within about 5 or 6 years, the PSA test became the standard for the early detection of prostate cancer. It's actually the only blood test available today that allows a patient, whether it's a man or a woman, to have an early detection for a cancer. Prostate cancer is the most common cancer in men, and the second leading cause of cancer death in men. 1 in 8 men are diagnosed with prostate cancer. So to be able to offer a simple blood test so a man can be diagnosed early, be safely treated, and not die from the disease is extremely important.
Yeah, that's an interesting subject, especially nowadays, right? With the news that we found out that the former President Biden had an issue with being screened for the PSA years and years ago. What do you think about that?
Yeah, I think that's unfortunate because the the Joint Task Force that helps perform recommendations for different testing no longer recommends, and they haven't done it for years, that men above the age of 70 should have an annual PSA blood test. And the reason they have this recommendation is because there's a fear that if a man who doesn't have a lot of longevity, so by age of 70, a man's life expectancy is about 15 years, then they're not going to benefit from having a test that then leads to the detection of cancer, which then will require a treatment. So in essence, the feeling is there's more harm than benefit. But the problem is you can't apply this rule directly to every man who comes in who's 70, because some 70-year-old men are going to live a lot longer. Whereas some 70-year-old men, because they've got comorbidities like diabetes, high blood pressure, previous heart attacks or cardiovascular disease, are not going to live longer. So you can select patients. So I think it's a bit unfortunate that a man like President Biden, who was a president, at that time he was vice president, where his personal physician decided not to get a PSA blood test. And then by the time the cancer was detected on President Biden, and I was 80 years old, but he's got metastatic disease, he's got high-grade disease, he's going to have to go on multiple therapies. Maybe he won't die from prostate cancer because of his age, but he'll certainly die with the disease and suffer the consequences of the multiple treatments he'll need.
Yeah, it's very unfortunate indeed, and I would suspect that at that level, the care of a person like that could be a little more under a very strict protocol. And I'm thinking, if I'm a 78 years old man, and I haven't had a PSA done in the past 5 years, why don't I do one? Like, what is the, I know it's probably not the indication at that point, but as a preventative measure, isn't that a good idea to do?
It could be, but again, there are many variables we have to look at. 78-year-old man, how healthy are you? Are you likely, you could live to 100. I mean, there are
Yeah,
more centenarians today than there were 20 years ago. But the other issue is, what was your last PSA? So if you had a PSA 5 years ago and it was 73 and it was 0.8, less than 1, the likelihood that you're going to have a fatal cancer now, 5 years later, is very small. You probably could forego testing. But at age 73, if your PSA was 2.5, you have a much higher likelihood of that PSA progressing to a number where you will have prostate cancer. So at that point, I would say if you were 73 and you had a PSA of 2.8, and you're now 78 and you haven't had one, you should have another one. That would be my
yeah,
opinion.
yeah. It's one of those things that it's almost like a common sense that it's not very common. Um,
It is.
and it brings the another discussion with what's happening now with the mammograms, right, in women. So the age limit goes down and down and down, and now they're even indicated below 40, just because you never know. Like we all know patients that had mammograms maybe year after year, and they skip 1 year for some reason, and the next time, they develop cancer. So I don't know what the real answer is to this, but I'm thinking maybe technology can solve some of these issues. And like you said, it's a simple test to do. Why don't we standardize maybe the protocols to have this as a screening done for every patient after a certain age? I don't know what the answer is, but I'm just debating the topic because it was in the news recently. You know, we all know the other person in the situation is King Charles of United Kingdom. So we definitely have a need for a solution on this topic. So let's go back to yourself and your developments. What can you tell about the recent technological advances in your field, and what can you do in the next near future with what you've developed already?
So I can address the advances that I have been a part of because they're
Yeah,
most specific to me. So I've always seen myself as an innovator and never willing to accept the status quo. So most physicians that go into practice and they practice what is the standard of care for their specialty. I have looked at the standard of care and evaluated where the weaknesses are. And then I have focused on, I'm a prostate cancer specialist, and I focused on prostate cancer. So when I came out of my fellowship at Memorial, that was in 1986, and I started at Sinai, the procedure to treat prostate cancer was commonly either external beam radiation or removal of the prostate. Nobody wanted their prostate removed in those days because it was a very bloody operation with a lot of side effects. There was no robot. So most patients went for external beam radiation. The problem with external beam radiation is the dose was too low for the cancers detected at that time. So many, and I say many, 40% of patients failed the treatment if they had localized disease. So I decided to create a new treatment that could deliver radiation. So I'm also a radiation oncologist at a much higher dose without complications. So we started working on that at Mount Sinai in 1990. And I started treating my first patients in June of 1990. And over a period of 8 years, that treatment slowly became more and more popular, where today everybody who wants to do this radioactive seed implant does the technique that I invented or developed with my colleagues. And it is probably one of the most successful ways to treat localized prostate cancer. However, during these last 15 years, new technology has brought urologists a robot. So now the majority of prostate cancer that's localized is being treated by what's called robotic prostatectomy. And in addition, external beam radiation, which was poorly done when I developed my technology, has advanced to where there's new equipment, higher doses are delivered, there is less side effects. So the treatment of localized prostate cancer has really benefited from these new technologies, the robotic prostatectomy, the use of image-guided and intensely modulated radiotherapy, and the technique I developed, which is called brachytherapy. So those have been really home runs. What can be done now to further the advances of treating localized prostate cancer? Because most men, unlike, unfortunately, President Biden, are not diagnosed with metastatic disease or advanced prostate cancer. That's only 10 to 15% of patients. 85% of men are diagnosed with localized disease. So now we put patients in two buckets. The ones that are diagnosed with very low-grade disease, almost like a colon polyp, where you don't need to treat the whole prostate. You can mostly watch the cancer and look for progression. So that's about half the men. 40% of men that are diagnosed, 30 to 40% of men are diagnosed with prostate cancer, have what appears to be a type of prostate cancer you could follow. Patients come back for yearly checkups, do not need any more treatment. The problem with our strategy, and that's called active surveillance, is that 40% of men who go under active surveillance end up having surgery within 5 years or radiation, because the technology we use today to make the diagnosis, which is a biopsy, all tumors today, solid tumors, breast, prostate, liver, lung, etc., get diagnosed by a biopsy. But the biopsy tools we use take a very small piece of tissue, and they are often wrong in terms of characterizing the aggressiveness of the cancer. And when they mischaracterize the cancer and we put the patient into active surveillance, they forego treatment, whether it's radiation or surgery, and some of those men can progress beyond the point of cure. Not all of them, but some of them. So my third company, I invented a new type of biopsy tool that takes a biopsy between 1.5 and 5.5 centimeters versus 2 centimeters. So now we can take 3 times as much tissue, so we get more tissue to give to the pathologist. They can make a more accurate diagnosis. So that was 10 years in development, and it was just FDA approved, and we're going to see the first patients get these type of biopsies starting in September. That advance, hopefully, will allow the urologist to make a more reliable and accurate diagnosis at the first biopsy and better select patients who should go on the surveillance, give them confidence that they have no worse cancer, and decrease the cost because we can decrease the follow-up tests that we need to do. In addition, men who have more aggressive cancer that are correctly diagnosed at their first biopsy can go on to some form of therapy without having to watch and then eventually find out later they really had a more aggressive cancer. So that's a brand new innovation that we hope will have a huge benefit to men with prostate cancer. Second, men would prefer to keep their prostates because when we do a prostatectomy, we affect sexual function and we affect urinary control. And even though the technology is greatly improved, those things actually haven't changed much. From the old way we did prostatectomy to the new way, we've decreased operative time, we've decreased length of stay, but we have not decreased the morbidity. So the thinking now today is if we can treat the cancer in the prostate just where it's located, almost like a male lumpectomy, it's been called that, where a woman who has the breast preserved and only the cancer is removed, so you have the cosmetics remaining for the woman, but for the man, we take out the whole prostate. Well, it's not a cosmetic issue because it's inside the body, but it's a functional issue. So if we could just treat the portion of the prostate where just the cancer resides, and the man is left with his sexual function, urinary control, that's a big advance. And so that's being actively pursued today. There are several new technologies out there that can do this, and we're starting to collect data that will hopefully show that this may be an opportunity for men with localized prostate cancer who don't require prostate removal or full gland irradiation.
Yeah, this is one of the topics that patients would probably want to listen to. That once they're diagnosed, the choice of treatments depend a lot on the side effects that they have. Um, what
Well,
is a cure?
it's the longevity and side effects.
Right.
Men in this case, always want to know whatever choice they made, they're not giving up
Yeah.
years of life.
Right. Yeah, exactly. And whatever life is left, what's the quality of it after that?
Very
You
important.
know, what is the cure rate in those cases of prostate cancer diagnosed in
Well,
general?
it's very high. So men with localized prostate cancer with a less aggressive type, let's call it, it's like 95 to 98%. It's
Yeah.
very high. The problem we have is men with high grade disease, like President Biden. So because of his age, he's most likely not going to die from prostate cancer. We don't know for sure, but the odds are he won't die from prostate cancer. But if he was, or a patient similar to him was 70 or 65 with that type of cancer, they have a 25, 30% chance of dying from disease.
Yeah.
That's bad.
Yeah. And again, we're going back to the early detection of those things by the only blood test that we know, the PSA.
Correct.
Let's go back a little bit towards your personal approach on your professional career. And I want to know what made you decide of going into this business side of things, those innovation side of things, rather than just staying as a practicing physician? Because I'm sure you had a great practice, a great environment to do that. You're really well trained. What made you decide that?
So I don't think I'm so unique. I think most of my colleagues, whether they're urologists or other physicians or other professionals not in medicine, we're all very bright individuals. Otherwise, you wouldn't get where you are. So the difference is coming up with an idea, which everybody can come up with. You know, everybody thinks, oh, this is a great idea, but then that's it, poof, it's gone. It's the perseverance and the follow through and taking your idea to a final stage, and that's hard work. And you just have to stick at it. So the first company I founded was Proceed. So Proceed was developed out of this new technique I developed for prostate cancer using radioactive seeds. And just like I'm an academician, I'm a professor of urology, radiation oncology, and oncological sciences at Sinai. So I teach all over the world, and it's always been my mission. But you can teach, and your students are only going to learn so much. Now, if they're your residents, they're with you for 4 or 5 years, they're going to learn enough to go into practice. But if you come up with new technology and you introduce it to your colleagues, they're not going to learn it unless you teach them like they were residents. And that's not possible in today's climate. There are no resources and nobody has the time. And so what happened was I started this prostate brachytherapy program at Sinai, and we started doing teaching courses. So it's 1994, we started in 1990. So 4 years later, we started bringing in doctors to Mount Sinai. We give half a day of lectures, we call it didactics. And then in the afternoon, we do 2 cases in the OR, and we broadcast them to the audience sitting in an auditorium. And we figured, okay, whole day, that's enough training. That was certainly more training than most people offered. Off they go, and they can do it on their own. And then I'd start getting calls from my colleagues as, Willie, can you come to my hospital and show me, or watch me actually, what I'm doing to make sure I'm getting it right? I said, sure. I'm a teacher, I'll go do that. So I would go to these hospitals, and if there were 1,000 things they had to get right, they get 5. I was like, oh my God, I created a monster, because if you put these seeds in wrong, patients have a lot of problems. They're just not, it's not only they're not cured, they get radiation damage to the rectum, to the bladder. It's a mess. So I said, what am I going to do about this? So I sat down and thought about it. I said, I need to start a company. The goal of that company is to capture all the variables, from the training to what equipment you buy to how you teach the nurses. And I'm going to put that all into one package, and I'll bring that to the hospitals, and I'll bring it in such a way that it costs no more money to the hospitals versus them doing it on their own, whether it be the doctors, or whether it be the administrators. So I figured out how to do all this, got some business partners, started the company. First year we had, this is 1995, three hospitals that wanted to do this project. Second year we had 7 more, so now it's 10 hospitals. So keep in mind, this is not watch these videos. This is go to the hospital, physically be with the physicians, nurses for 3 cases, train everybody, the urologist, radiation oncologist, the physicist, the dosimetrist, and then you're done. Well, it never was one day. The average was 5 trips, at least 15 cases. So here I am, and I have 2 colleagues helping me. Now it's the second year I have 10 hospitals requiring 50 visits. In the third year, I signed up 30 more hospitals. So now 40 hospitals. And I'm working 120 hours a week because I have my full-time job at Sinai. And I'm the only one that's in the East doing this procedure because most people know how to do it. So people are coming from all over the world to get treated. So I'm like, I'm going nuts. I thought I was going to have a heart attack at age 45 doing this. And then the third year, we got approached by a company called C.R. Bard. C.R. Bard was a urologic company that sold disposables, but they sold it for many specialties, but urology was one of their big companies. And they came to us and said, we want to buy your company. We said, what? We weren't thinking of selling the company. We said, why? They said, well, disposables, we want to sell the radioactive seeds. We want to buy your company. So 3 years out, I sold the company to them, went to work for them for 6 years. First year I worked for them, which was 1999, I was on the road 242 days teaching. You can believe that. Then I finally started training other people to do the teaching. Then I started going to Europe. In the year 1999, I would go to Europe 1 week a month, different country every day. Fly back to New York, do my practice, work at Sinai. Then in 2007, the Japanese decided they wanted to learn this technology. So from 2007 to 2015, I made 20 trips to Japan. I trained urologists in 100 hospitals during those 6 to 7 years. So I basically trained the whole world. But everybody I trained, because I stayed with them till they were proficient. I never let a urologist or radiation oncologist do a case on their own till I decided that they could do it safely and correctly, which meant some cases 3 visits, some cases 7 visits, because doctors learn at their own level. And my students have published data all over the world, and they do everything beautifully. They do it really well. But at the end of the day, it's the patients that benefit from this because they get a great treatment. So that was my philosophy. And I developed that philosophy when I was a resident at the University of Maryland, because as a resident for University of Maryland, we would spend time at Johns Hopkins. And at Johns Hopkins is this famous urologist. His name is Pat Walsh. He invented the way we do prostatectomies today. So everybody would want to come to see Dr. Walsh. And Dr. Walsh would say to them, if you want to learn how I do my surgery, which was a major advance, you have to come and watch me. He never went to them because that's not what they did in those days. So people would come and watch. But when you go and watch something, you don't learn enough to become proficient. So I decided I'm never going to, and I tried to come and watch me. I found that it was a disaster. So I decided it's my responsibility. I need to go to them and make sure they get it right. And it just worked out. That was company number 1.
That's a lot of dedication, a lot of passion, and a lot of, I would say, grit to do that with so many hospitals and so many other doctors. And thank God of somebody like you.
Thank you.
Now, if you look back, I'm sure your success in all these ventures, medically and business-wise, is based on the fact that you never gave up. But I'm sure there were some setbacks or something along the way that didn't necessarily work out and kind of made you maybe go forward faster because of that. Can you give us an example of something like that?
Sure. I think it's a really good question. 2 years into starting the brachytherapy program, 1992 at Sinai, I'm talking to one of my urologic surgical colleagues at Sinai, and when you take out a prostate, the man's PSA goes to 0 because there's no prostate. And at the time when we were giving radiation therapy externally to patients, the Radiation Therapy Society was happy if the PSA went to 4, not to 0, to 4. So I'm treating patients with a higher dose of radiation with the seeds, and the PSA is going to 2. So I'm like, this is a great success. So I said to my colleague, I'm really happy. He looks at me and goes, when I take out the prostate, the PSA goes to 0. So immediately I go, oh my God, why isn't the PSA not going to 0? So at that point, I'm thinking, I created a new treatment. And at the end of the day, it turned out to be a big disaster. And there was precedent for this because when I was training at Memorial, they were doing the same technique, only they were opening up the patients and putting the seeds in by hand. So this little seeds, they're 4.5 millimeters long and they're 0.8 millimeters in width. They're titanium shells with a radioactive element inside. So you have to put them in with a lot of accuracy. But they weren't able to do that at Sloan Kettering, and it turned out to be a total disaster. Patients had a lot of side effects, and the recurrence rate was really high. So in 1987, My mentor who started this, Dr. Willard Whitmore II, abandoned the treatment, and everybody said it was a bad thing to do. So here I am in Sinai 3 years later doing the same thing, but with new technology. That's, that's how medicine is. And people were saying to me, what are you, out of your mind? I mean, I got a lot of criticism because I'm doing something that was a failure but people didn't understand what it was about. They only saw the periphery. That's how life is. Look at politics today. You don't really know what's going down deep inside. So I just thought hard about it. I looked at what we could do, how we could improve, and how we could get to that point where the PSA would go to zero. So I just doubled down, spent more time working on it, and finally got to the point where it needed to be. And that's the whole thing about perseverance. And we got the PSAs to zero with no more side effects.
Yeah.
Most likely, this treatment that we do today has a fewer side effects compared to surgery, because you don't have the same urinary or sexual side effects, or external beam radiation, because we can give a higher dose and we're more likely to kill the cancer than just giving external beam radiation. So it all was a matter, as we said before, of just persevering. It's easy to give up. It's harder to stay the course. And the chances of failure are always high. But if you know your subject very well, then you're less likely to fail and more likely to succeed.
Yeah, that's so true. I was about to ask you to follow up on this. Like, what do you think the main habits and routines and qualities that you have and you practice every day that brought you to this level?
I don't think I'm any special or different than anybody else. I just think I look at things maybe a little differently. And while I really enjoy patient care and solving problems for patients and getting them past difficult times, to me, if someone's properly trained, anybody can do it. So then the issue is, what's the state of medicine today, in my specialty, for example, and how can we improve it? And who's going to do it? So urologists know best how to fix problems that are in our own area of expertise. Whereas companies that come up with ideas, introduce new medical devices, they're usually business people. They're not necessarily practitioners. And so I meld the two together so I can see what's needed from my own experience, which is very important. And then I can figure out the solution. The problem comes, how do you get from figuring out the solution to actually having the solution? And that's where I think one develops that skill. So somebody could be a great entrepreneur, Bitcoin or something, and figure out how to do all that. Is it really needed? I guess if you want to make more money, it is, but that's not my interest. My interest is in patient care. So to advance patient care has always been the challenge, and I like challenges.
Yeah, I like that. People usually they like challenges. They like to solve the challenges too. Um,
Mhm.
if you if you would look back into your early years with what you know right now and the wisdom you have and the experience you have, what kind of advice would you give to yourself?
To myself. I usually give advice to everybody else because I'm teaching
I
all the
know.
time. So, but that's a good question to myself. See, I grew up with a father who's a neurosurgeon. So I grew up in a medical family. And he used to take me to the hospital with him on the weekends when he would make rounds. And I was maybe 10 years old. He would say to me, sit in the car, listen to the radio. He'd park right in the emergency room. You can't do these things today. But in the old days, you could do this stuff. I'm going to run in and see a few patients. So I'd be there an hour, 2 hours. Like, well, this is ridiculous. So the second time he took me, I said, I'm coming with you. So as a 10-year-old boy, I would make rounds with him. And I was just fascinated about his approach, the way he would deal with patients, from understanding the problems and immediately reacting when there was emergency. So I wouldn't change that. Um, you have to make a sacrifice when you get to the point where you're working so hard. And so what you sacrifice is your family. So advice would be like, you need to spend more. I have 3 kids, they're great kids. Oldest is an emergency room physician in Colorado. Second is a neurosurgeon in upstate New York. And the third one is a business person who works in one of my companies today. So advice is always try and spend as much time with your family. And the way I solved that problem, because I needed to travel, is I would take it with me. And so I'm not giving advice to myself. I'm giving advice to other people right now, which is not the question you asked me. I'm trying to think of what advice I'd give to myself. Maybe take care of yourself better, because when you're traveling so much, you tend to eat the wrong things because that's all you have, and you don't exercise enough, and you could sacrifice your own health which is easy to do because you don't pay attention to your needs, your normal physical needs. Because if you're a person who has all these capabilities to help other people, you need to be around a long time.
Yeah.
So you have to pay more attention to your own personal needs. So I think that would be the advice I would give to
Very nice.
myself earlier on in my career, which I didn't do. I do it now, but I didn't do enough of it then.
Very nice. So what's new for you now? What are your projects? What do you look forward to do? What's your new company doing?
So it's funny that I had dinner the other night with a colleague of mine and his wife. He's a retired anesthesiologist. I just retired 3 or 4 years ago from Long Island. And I said to him, Steve, well, so what are you doing this week? He goes, so, well, okay, I got pickleball at 8 o'clock, and then I'm going to go play golf, and then my wife and I are going to go hike. I said, sounds great. So we get a lot of exercise because my wife and I do a lot of road biking. So, 30 miles in 3 hours is a good amount of exercise, especially riding at altitude. So we do that 3 or 4 times a week. But right now, medical technology is coming out so fast. There's 50 new medical devices released per year. And the ability for busy surgeons, whether they're urologists or any other type of surgeon, to be able to understand and learn how to use this new technology is so limited that they're thrown into it and they're learning on the job, which is not a good thing for patients because it takes a lot to learn on the job. So my son, who's a neurosurgeon in Rochester, invented this technology to make artificial cadaver. So they can build an organ system, excuse me, that are 3D printing and polymers, and you can practice any surgery.
Wow.
So there are a lot of urologic device, device, too much talking.
Take your time.
There are there are a lot of new products. Gonna need a minute.
Yeah, that's an amazing idea. I never thought of someone like doing that.
So we
I
started
don't
a
know.
company in 2018 out of the University of Rochester to sell these new synthetic models. So for example,
Do they look like a mannequin or
well, they're,
how
they're
do
body parts. So you don't have
oh
to
they
build the
body
whole body
parts?
because it's
I see.
specific
Yeah,
to
I
a
see.
surgical procedure.
I see.
So for example,
So
we
if you want to practice urology, for example, you only have the pelvis or something like that, right?
or maybe the prostate
Oh,
inside of
I
a
see.
model.
Yeah, yeah,
Well,
yeah. I see.
new procedure is to use a laser to carve out the inside of a man's prostate to open up the urinary channel so they can urinate better. And that procedure requires practice. So we built a model that looks exactly like a patient inside.
Wow.
You can't tell the difference between our model and operating on a patient. So surgeon can practice because it's kind of tricky how to put the laser in right and find the right space. But once they practice with the model, they can do it on patients. So we started that in 2018, and now we sell these models to almost 100 companies worldwide. The next problem with this is, you remember what I told you about me traveling all over the world. Well, nobody has time to go teach this. So we got a great model, but there's nobody with expertise around to teach because they're all too busy in their practice. And nobody wants to leave their families anymore and travel to another site. So our next invention, which we just released, is a headset. It looks similar to a Microsoft HoloLens or maybe the Apple Vision Pro. You put it on your head, and it allows somebody who's remote, like you and I are now, to see what I'm seeing. So if I'm looking at the patient and I've got this headset on and it's got cameras in it, you can see what I'm seeing. So you've got my eyes. It gives you first person view. It also allows you to take any medical imaging and put it in your eyes. So it has lenses that are basically see-through screens that project the medical imaging, say from an ultrasound, a
Oh,
fluoroscope,
wow.
a camera that's a cystoscope or colonoscope, and I can project those images also remotely. So if I'm the student doing the technology, a new operation that I need to learn, and you're my instructor, you see what I see not only in front of me, but you see the same images I'm seeing, which I'm seeing in my eyes, and now you're seeing on your computer. and I can arrange those images anyway. You can even teach me, we call it live annotations. You could draw an arrow to a specific point, and I'll see that in my eye. I am no longer, we typically do image-guided surgery, and we look at a monitor over here, and our hands are down here. I'm no longer looking at the monitor because the monitor is in my eyes. So now I can teach 100% as if I was with you, only now I'm remote. So that new technology we just introduced last year. And it's funny, the company where I introduced this new biopsy needle, the company has to train everybody how to use the needle. That's mandated by the FDA. So now they can train with our headset. They don't need to have doctors go to you. If you're the student at your clinic, they can send you the headset. You got the needle, you got our Phantom, we call it, our model. You can practice wearing the headset, do the biopsy on our Phantom with ultrasound. Then we could watch you do this first 15 or 10 cases, see everything you see, we'll see. And I can do it all remotely now. So
that's amazing.
What we have now is a surgical education company that supplies the Phantoms to do the training and the headset to do the remote teaching so people don't have to travel. The big home run here is, and this is, again, developed for our colleagues to improve their surgery. The future of the OR will be no more monitors. I don't know if you've ever been in an OR. You probably have. You see monitors all over the place. You see doctors looking up at the monitor. You see the anesthesiologist looking over at monitors. Everybody will be wearing this headset in the future. 125 million image-guided procedures done a year. Every surgeon and interventional radiologist will be wearing a headset, because when you have your images in your eye, you're no longer staring up there. You can look at your hands, look over here, you look over there. This is going to be one of the biggest changes to surgery that's going to happen in the future. Wearables, just like a fighter pilot has a screen in front of him. So when he's up there, or she's up there, altitude, targeting, fuel consumption, vitals are all available to that pilot. When we operate, we stare down an operative field and we have nothing in front of us other than the operative site. We have no idea what's going on with the blood pressure, the pulse, any type of imaging that we need to see. In fact, what happens is we're there operating and all of a sudden the anesthesiologist yells at us, the blood pressure is going down, the pulse is going in. We're like, what? We are shaken awake out of our bubble of surgery. No more. That information will be in your eye. You'll always have it as a surgeon, and you can make critical decisions in a timely fashion without compromising patient safety. This is the future we're working on right now.
That's fascinating. I'm amazed of how things are evolving and the speed that they're evolving to. And I'm thinking, the old-fashioned way of doing surgery and anesthesia these days is probably going to go away very fast with this kind of technology coming in, and probably AI that's going to be integrated and gives you solutions and all kinds of stuff. Dr. Stone, it's been a pleasure to have you with us, and I want to know, how can people reach out to you, learn more about what you're doing and your development?
Well, I'm very simple. I always make myself available to my patients. So my email address is drnelsonstone@gmail.com. So DR is abbreviated, Dr. Nelson Stone. And so it's my name, .gmail, so anybody can reach out to me. And I stopped practicing medicine, although I still teach, and I teach in the OR all over the world, but I don't see patients on my own. But I get calls and emails all the time from patients with prostate cancer who ask me for guidance. And I'm not their physician, I tell them, but I can talk to them. I can guide them to a place where I think they'll get good care. And so I just do that as part of who I am. So I'm happy to help anybody that needs help.
Amazing. Thank you very much. Wish you much success from now on.
And a pleasure talking to you.
Are you a busy medical professional striving to excel in life and work? Stellar Success Podcast brings you the habits and insights of top leaders in medicine and beyond. Discover strategies for balance, growth, and fulfillment in every episode. Follow us on Instagram @Stellar Success Podcast for daily inspiration. Start your journey to success today. Subscribe to the YouTube channel now.
That's a wrap on Stellar Success, Leveling Up for Medical Pros with Dr. Tudor Francu. Interested in joining us? Go to stellarsuccesspodcast.com /guest to apply. Stay stellar and level up.